I'm in solo private practice as a radiation oncologist, and I'm confused when I look at MIPS. Should I be using MIPS CQMs or eCQMs, or should I be using MVPs? Some of the measures I have used in the past are no longer available in traditional MIPS, but only in MVPs.
Great question, Sally. Well, if you've been consuming many of my Ask Dr. Mingle sessions, you'll know that generally I recommend the MIPS CQMs over eCQMs. And that remains true in this case. I don't see any advantage of you going to eCQMs rather than MIPS CQMs. MVPs, there's not a radiation oncology MVP yet. So that's out of the question. Although for a brief period of time, anyone, whole groups can be using MVPs. So as a solo practitioner, you too can use that. So if you have an MVP that you can make work, by all means, but there's nothing well suited to a radiation oncologist. You'd be counting on, as you are now, you'll be counting on what we call the halo effect. I'll get into that in a moment. And certainly the four measures that have been retired from general MIPS menu of measures and are now only available in MVP measure sets are preventive care and screening, that is influenza immunization, another screening, breast cancer screening, colorectal cancer screening, and body mass index screening and follow-up plan. Those four all have that dynamic that they've been retired from general MIPS usage, but still maintained for usage in certain MVPs. Now, these measures have never been perfect radiation oncologists. In my experience, these actions are not typically within the expectations of radiation oncologists. You're seeing people for the breast cancer or for the colorectal cancer or others and not ordering the screening test. That's usually up to the primary care provider. But they're good measures for you because they are usually recorded in structured fashion, and many radiation oncologists have access to data that they can report and benefit from in what we call the halo effect. That is, someone else's excellent performance on that, if that data is available to you, can qualify you for a favorable scoring in MIPS. Now, as I said, there's not yet a radiation oncology MVP, so there's no help there. And I expect you can still find 6 measures in MIPS you can report enjoying the same halo dynamics of the 4 measures that have been excluded from your use. It's possibly the best bet that the radiation oncology measure set is your best choice. Medicare has prepared a number of measure sets specific for specialists. They look across their measures and said, we think a radiation oncologist can submit these measures. We think an oncologist, a hematology oncologist submit these, et cetera, et cetera. And the interesting dynamic of those specialty measure sets is if there's less than 6 measures available to you in those measure sets, reporting those measures is enough. So specifically for the radiation oncology specialty measure set, there are 4 measures. Number 102, avoidance of bone scan for staging low-risk prostate cancer patients. Number 143, pain intensity quantified. Number 144, you establish a plan of care for patients who report pain. And number 226, you're screening for tobacco use and you're intervening when the screen is positive. So those four serve as the only requirements of a radiation oncology specialty measure set. They could be included in an MVP, but they're not yet. But the dynamic of this, if you report those 4 measures, there's no penalty for missing 2 of the typical 6 measure set required of MIPS. They reduce your denominator to 40. That is the number of measures times 10, and you can get a perfect score from that. or regardless, whatever combined score you get, it's divided by 40, not 60. Now, if you're going to do the measure group, you have to submit all 4 measures. If you miss one of the 4 measures, I'm not sure exactly how they're going to handle it, but it's possible you'll get scored. Your score will reflect 3 missing measures, not only the one from the radiation oncology measure group, but you're no longer getting credit for the measure set because you missed one of the measures. So you may be missing 3 measures, not just one. They'll take your total score and divide it by 60 instead of your total score and divided by 30 or 40. Now, if you have no patients eligible for the measure, and it's hard to imagine the radiation oncologist isn't going to have pain intensity and the opportunity to have a plan of care for pain in your environment. And of course, every patient is susceptible to tobacco use screening and intervention. So the one that makes a reasonable case study is the possibility that you're not caring for doing prostate cancer patients. So in that case, you can do 3 measures, but not the first one. And you take care of that by reporting a 0 over 0, a 0 denominator. I have no patients eligible for this measure, and a 0 numerator, no performance because no one is in the group. And when Medicare gets that, they give you credit for the 4 measures, or if for a full measure set, they actually change your denominator to 30, so 3 measures can give you a perfect score. So that's think hard about that radiation oncology specialty measure set. We'll keep watching for an MVP for you, and good luck with your reporting this year.